if we see the recent events in early 2026, you must have found several uh, outbreaks being reported, but only what do you mean by outbreak? An outbreak is when more disease occurs than what you generally expect. So let's say if you're expecting maybe 5 cases of one particular disease in an area, anything above 5 we will call an outbreak. But it doesn't have to be 5. For each disease, there will be a different threshold, which we call as triggers. So now, not all outbreaks are called PHEIC, but when few outbreaks are called, why do they call? So we need to the national health regulations. According to this, any extraordinary event in terms of these outbreaks that has public health risk, which means people are at the risk of getting the diseases from that particular agent, and it has potential to spread, and it requires more than just local management. It would require international coordinated response, and countries should be able to respond to these heightened risk. First of all, manage the borders, or should they look at increasing the capacity of their hospitals, testing? All these things will take a different level of seriousness the moment it is called as PHEIC. So what makes the outbreaks a PHEIC or not? So there are a few criteria, and among these 4 criteria, at least 2 have to be met to call as a PHEIC, which is public health emergency of international concern. First, that the public health impact is serious. Second criteria is the event is unusual or unexpected. The third criteria is there's a significant risk of international spread, risk of restrictions on international travel or trade. So to declare a PHEIC, it triggers global coordination. It mobilizes resources. You'll have to get more experts involved in, and it also provides recommendations aimed at reducing transmission while avoiding unnecessary interference with travel and trade. So that's the goal of declaring it as PHE. So let's try to understand what's happening in the recent Ebola outbreak. The virus behind this crisis is not new. What is named now as BVD, Bundibugyo virus disease, it's one of the 4 Ebola species capable of infecting humans. It was first identified in Uganda in 2007. What makes this event extraordinary? So it took really long time in terms of missing this deadly outbreak for the authorities to realize which pathogen they were fighting. So whenever you want to start investigating an outbreak, if you do not identify the pathogen, we say disease of unknown origin, or we call it as agent as an unknown origin, and then we start investigating. And if it takes longer, then it is unusual and extraordinary. Why it is extraordinary? In late April, a gold miner in Ituri province, DRC, developed fever and weakness. Within 3 days, he died. Over the next 2 weeks, similar illnesses which had fever, fatigue, vomiting, and occasional bleeding appeared in Mongboalu and Rampara, bustling mining towns where people arrive, they work, they depart. There's a lot of movement that's going on. Now, local health workers performed rapid tests because this occasional bleeding, the symptoms that fit in, and Zaire Ebola virus was generally prevalent, and therefore they had rapid tests against it. But they did not get the results positive. So all the results were negative. Now, you would be concerned if you were running the local health authority that here is an illness which is spreading, where are deaths occurring, and we don't know what it is caused by, and it is negative for the Ebola virus. That's why it triggers as one of the criteria as an extraordinary event. Now, when you do not know what the agent is, communities definitely will have heightened sense of vulnerability. There is some amount of panic, and people start assuming that it can be malaria, typhoid, whereas the real culprit, the Bundibugyo virus, is not recognized. Now, remember, it happened in late April. Till 14th of May, when samples were sent nearly hundreds of kilometers away to the National Reference Laboratory in Kinshasa, a correct species was identified. So we have already lost some time in understanding what is the causative agent here. Now, if you see in terms of the entire timeline, which I'm showing on the screen, the real problem in this outbreak detection and response is the timeline. The first illness is in late April. On 5th May, World Health Organization notified that a high mortality illness of unknown cause is occurring in this region. Since rapid tests continue to return negative, it's only on 14th May that the national lab confirms the Bundibugyo virus. And on 15th May, both DRC and Uganda ministries of health formally declare these as outbreaks. By now, 3 weeks have already passed. An eternity in outbreak response, because whenever you have the first case, which we call as the index case, is identified, whenever there is an unknown origin is suspected, the outbreak response has to be immediate and specific. But here, it was delayed because of the want of having a known agent. But during this period, this viral hemorrhagic fever was circulated through highly mobile mining communities. You cannot stop them, it is there daily earning. And nobody knew what the disease is. By 21st May, when WHO reported 746 suspected cases and 176 deaths in the DRC, among them 85 were confirmed. We will go into the details of the differences between what is suspected, what is probable, and what is confirmed in a bit. But these are the statistics. Only 85 cases were confirmed. But there are already 10 deaths. But we have to be very careful when we look at these numbers. These are just the reported numbers, which means that more than 90% of the recorded infections are suspected, but because you do not have the lab capacity, you will not be able to diagnose, and therefore you will not have a confirmed case in each of these patients. So if you look at the comments of the epidemiologists who are closely examining this, they are suspecting the real numbers may be really high, with several clusters of unexplained deaths still under investigation. Now, by the time the detection has occurred and confirmed, the outbreak has already spread across multiple provinces. You look at Ituri, North Kivu, South Kivu. It has reached major cities like Goma, Butembo. An imported case in Kampala, Uganda, died after hospitalization, and another imported case was treated in Germany. Now, most confirmed cases occur in adults aged 20 to 39, with two-thirds in women, reflecting the kind of risk the caregivers and the mining labor dynamics, which is I have tried to explain in my blog in the link below. So, in summary, there was a cluster of several deaths with an unknown origin. It took some time for diagnosis. By then, it has already spread across many districts locally and also internationally. Now we would see that it meets more than two criteria of PHEIC, and that's why World Health Organization declared this. We define surveillance. You might have heard surveillance as a common English word in different contexts, but when in epidemiology, when we say surveillance, it means collection of data related to any disease and making sure that this collection of data and then analysis of this data around that result in an action that we take. And the action is to control the spread, limit the morbidity or the complications of the disease, and minimize or not ideally not have any deaths. So surveillance is collection of data for action. This is the phrase that we can remember. Now, as I explained earlier, we have missed detecting in time. Why? There are reasons why the outbreak was not detected in time, and why we say surveillance has sort of been slippery or not to the expected standards. There are many factors here why this outbreak was missed. First, we need to recognize the first one is diagnostic blind spot. A rapid test like Bunia and other local clinics were designed for Zaire Ebola virus. They cannot detect the Bundibugyo virus. So when the tests are negative, clinicians generally have to make another differential diagnosis. So you miss Ebola, but then you start treating like other illnesses which have same symptoms, while the disease is actually spreading. So WHO later explained that the existing gene expert platforms cannot detect the Bundibugyo virus, and emphasized that RT-PCR capacity should be enhanced, and we should also probably have more point of care assays which needs to be validated. So surveillance is only as broad as the questions we have and the tools we have, including the tests. So that's one problem. The second problem is BVD is a clinically slippery disease. It has symptoms like fever, muscle ache, a headache, and fatigue. You can think that it might be a viral illness. It can be malaria, it can be typhoid, even COVID-19. And some of the hemorrhagic signs, such as bleeding in the mucous membranes, they occur much later, and therefore the initial presentation looks like it's any other disease. In resource limited or constrained settings, these non-specific symptoms are generally treated like any other endemic disease, and therefore the transmission is continuing because it's a slippery disease. Now, the another factor why it has missed is you'll have to understand the context where it has occurred. It's in a fragile setting. Ituri and the neighboring North Kivu have endured protracted conflict in this region. There's displacement and there's humanitarian crisis. There have been several reports of attacks on the health workers, the roads are not safe. Therefore, and also some of the region is outside the government control. While the virus is spreading in urban and semi-urban mining towns and trading hubs, the remote villages and the populations that are highly mobile, they are not captured. So therefore, all these conditions have resulted in an illness being protracted for a long time and not detected in time, and also we have missed the crucial time to contain this outbreak. Let's try to understand the transmission, origins, and how it is spread. Bundibugyo virus is one of the 4 ortho-Ebola viruses. It's a group of viruses which will cause illness in human beings. Fruit bats are supposed to be one of their natural reservoir. The infection in humans occurs only when there is the contact with an infected wildlife or their secretions. Then the transmission is amplified through direct contact with the blood, secretions, or the organs or body fluids of infected individuals. Also, it can occur if there is exposure to contaminated objects or through unsafe burial practices. Most importantly, PVD does not spread through air. So people are not contagious until they develop symptoms. The early symptoms, these are what we call as dry symptoms. They're like fever, muscle ache, fatigue. And then starts the wet symptoms, which include diarrhea, vomiting, and unexplained bleeding. This means the risk to people outside this zone of outbreak is very low. And if the cross-border spread is happening because of high population mobility, porous borders, and the fact that Ituri is a commercial hub close to Uganda and South Sudan. The 2 imported cases in Kampala illustrate how easily virus can spread across these borders. Now, the real problem is the severity. This virus has a case fatality rate of 25 to 50%. Although it's lower than the average of all the Ebola virus diseases, but it's still severe. What does it mean? Among those who are deceased, when do we say it's diseased? They have symptoms, it's confirmed. So let's say there are 100 such people. Out of that, there is a chance of 25 to 50% of them, which is 25 to 50 of 100 people dying because of the disease or its complications. This will change if more suspect cases or lab confirmed and early response is there and treatment facilities are there. But preventing its spread as early as possible is most important in these settings where we do not have the facilities to treat all the patients or even diagnose all the patients. So WHO assesses the risk at the national level in the DRC, and then it said it's high. It's also high at the regional level, but it has clearly said the risk is low globally. And the cross-border case, which is treated in Germany, it shows that BVD can reach even high resource settings. And however, the risk of onward transmission to countries with strong infection control is extremely low. So it will not be a cause of concern of rapid spread. No licensed vaccine or specific treatment. And therefore, in those who are infected, deceased, supportive care is what is most important. Unlike Ebola virus disease, usually caused by Zaire Ebola virus, there are some experimental therapies that have shown efficacy in animal models, but nothing has been approved for human use. Therefore, outbreak control, which includes early detection, isolating the virus rapidly, high quality supportive care, safe burials, and community engagement and contact tracing are most important. The rapid supportive care, such as fluid replacement and management of bleeding, can actually reduce mortality significantly. And healthcare workers must use personal protective equipment and should follow strict infection prevention protocols to avoid their risk and the complications. Definitely gives false alarms when of saying negative, or we say false negative. There is a disease, but you're trying to detect another causative agent here. As WHO recommends RT-PCR testing, it's important that newer point-of-care assays are developed, validated, which can differentiate between the species of Ebola. And labs need to be strengthened, they need to be decentralized. Beyond these diagnostic issues, is what we should focus is on weakened surveillance and why it is so now. For many decades now, fighting diseases such as Ebola or any of these endemic diseases, they've all been supported by funding from global health organizations. This included be it lab network strengthening, having people working in these settings, strengthening platforms where data was collected, reported, analyzed. All these functions of surveillance now have been stopped or stalled or minimized. Why? Because there's no longer funding available. We know all, as of now, if you look at just the data from IHME, Institute for Health Metrics and Evaluation, they show that the development assistance for health has declined nearly 21% between 24 and 25. Even though it's decreased only by 21%, majority of this decline, nearly around 67%, comes from US alone, which is nearly $9 billion US dollars. So therefore, sub-Saharan African countries, particularly those with the small budgets, they have been hit hard. There is reduction in the total health spending up to 16-17% because of the lack of global health support is here at play. And one of the factors is weakened surveillance systems because of the funding cuts. But conflict, mobility, clinical ambiguity, all of them have played their roles. So the virus, the Bundibugyo virus, is a viral disease which we call as zoonosis. More than 80% of all the future outbreaks are going to be zoonosis. Zoonosis are the diseases that are generally present in animals, but then transferred on to human beings. This virus resides in bats and occasionally spills to humans at the messy interface of people, livestock, and wildlife. Mining, deforestation, land use change, and the migration of the people in these areas, they all expand this interface. Now, outbreaks of zoonotic diseases are signals of the ecosystem that we live in. And this is what One Health is. One Health is the interface between animal health, human health, and environmental health. Now, communities which are most exposed to wildlife contact have been the starting point of this kind of outbreaks of zoonotic diseases. So if you want to strengthen the surveillance, we cannot simply have only primary health care and hospitals being strengthened, but we also need this interface being detected, and therefore not just the routine health surveillance system, we also need community-based surveillance, which means the moment there is any unexplained death or any hemorrhagic death occurs, the community health volunteers or the community itself, in collaboration with their traditional leaders, they report to the health system and we can start the outbreak response. So protecting the forest and ensuring wildlife trade is minimized or eliminated will also minimize the spillover risk from animals to human. So the One Health approach of integrating human, animal, and environmental health must move from a sort of a rhetoric to implementation. So who should worry? Is this risk for everyone? People who are all over the world because of the COVID-19 are now questioning, is this something risky for us? So let's go through the details. For people living far from this outbreak region, the risk is almost negligible. We can't say it can never occur, but then it's extremely low for anybody outside this region. So that's the first thing that we should be aware. Second, it does not transmit through air, and individuals are not contagious until they have symptoms. So these are very important considerations. And travelers need not panic if you're not in contact with the secretions or in the outbreak region. Then who should be careful? Health workers, caregivers, and burial teams. In these provinces where an outbreak is occurring, they are at the highest risk, especially if they have contact with the blood, vomit, or any other bodily fluids, which is the main route of infection. Therefore, how do you prevent? Personal protective equipment, follow strict infection protocols, control protocols, and seek training if people don't know how to follow these protocols. The second group of people who are at risk are family members and caregivers of the patients. They should be careful, avoid touching body fluids, practice hand hygiene, and ensure they seek care in designated treatment centers for people who are deceased. And safe and dignified burials is very important, both as a matter of respecting the individual who is infected, but also in terms of preventing its spread. If any of you are traveling to DRC or Uganda, CDC advises avoiding contact with blood and body fluids of people who are sick, not touching the body of someone who has died from suspected or confirmed Ebola, avoiding exposure to bats and other wildlife, and not entering mines or caves where bats live. So travelers should avoid all these things. And do not visit also facilities for non-urgent reasons, and a facility is taking care of people, so that will help them prioritize. Plus, it will also prevent spread. Those who are working in mining industry, logging, and bushmeat sectors, these people are at risk also because they are in contact with bats and wildlife, and workplace health and safety training and again personal protective equipment are important for them. Many people survive. Most important thing is to not to stigmatize the survivors. They can return to communities once they recover. So we need to be careful and treat people who are infected with dignity and empathy as we move from outbreak to non-outbreak settings. CDC recommends systematically assessing patients with symptoms which are compatible with this disease, which I explained earlier, for a history of travel or exposure to people with the disease. They should be, we should be vigilant and then see whether they have these symptoms developing or not. Any test that detects these symptoms in travel should include BVD as one of the differential diagnoses. Clinicians should collect appropriate samples and test even when they suspect malaria or viral illness or COVID-19, especially if they have traveled or been in touch with patients, especially caregivers. They should be isolated the moment we know there are symptoms. Any person who has symptoms should be isolated till the test results are available. At least 72 hours after symptom onset is the critical period for isolation. And we are all familiar with what isolation means. So they have to have the capacity built within the system to improve the point of care tests for different species of Ebola. And if there's a new zoonotic disease, we should be able to identify the index case and then start isolating the virus as early as possible. And for this, we have to expand genomic sequencing near outbreak hotspots and also enhance the RT-PCR point of care assays. So that is the first thing. Widen the surveillance network and strengthen it. Second aspect is to decentralize and strengthen lab. You cannot just have one national lab or one or two regional labs. You have to have many provincial level labs and sub-regional. And these labs should also have biosafety training, what kind of safe procedures are involved in sample collection and protocols around quick turnaround. So these should be there in place. The most important thing is to strengthen field epidemiology training between crises. Strengthen hiring and sustaining local workforce in epidemiology, contact tracing. Therefore, community health workers should remain ready between outbreaks. That's when the training should occur so that they know an emergency when there is one. Reinstating programs like Stop Spillover and preserving the polio era surveillance network. In many countries, the surveillance medical officers and the infrastructure of polio surveillance has been completely defunded and removed from the healthcare systems, since polio is not a problem there. But this is the strength of that system. These are world-class trained workers who can take care of these outbreaks. And I mean, whether we like it or not, in our lifetime, we are going to see many more outbreaks. To prevent its spread, to strengthen the health of thriving populations, we need these infrastructures to remain. The next important point is to sustain financing for preparedness. Surveillance and preparedness cannot function without funding. Governments and donors must reverse aid cuts. A problem somewhere in Africa may not haunt you now, but when it haunts, it will be too late. So therefore, development assistance for health is global public health good. It's not just global in the sense that it helps somebody remote, it's also going to help locally. Therefore, global is local. You have to take care of your own population by investing in such outbreak minimizations. Implementing a One Health approach is an important aspect to strengthen. We have to monitor wildlife, livestock, and human health simultaneously. And we cannot have isolated efforts. These agencies need to talk to each other, supporting research into bat ecology, land use, mining practices, which drive the spillover, and then minimizing spillover is an important aspect. This will definitely involve offering alternative livelihoods to reduce their reliance on activities that will expand the human-wildlife interface. So therefore, it's not just research, it has to strengthen their day-to-day life in terms of taking care of their livelihoods. Two other important aspects is whenever such an outbreak occurs, and this is one of the reasons why I had to do in YouTube for the first time, is to communicate. People are scared. They press the panic button, especially after COVID-19. Therefore, it's our responsibility who are in health sector to communicate transparently and respectfully. We have to spread this information to community leaders, the traditional healers. We should have a clear, culturally appropriate and sensitive information about symptoms, how to prevent them, and what is the importance of early care. All of this is very, very important. With so much of misinformation and rumor, we need to up the ante for communicating in timely manner. The last aspect is to advance research and development. This time it is BVD, but there will be other viruses in future. So what we need to strengthen is the entire pipeline for research and development. So the absence of licensed countermeasures, be it vaccines or treatment, is the single most problem in tackling unknown diseases. So vaccine development should be coupled with hastening or rapid regulatory pathways. But most importantly, whatever the output of that is should be equitable. People in the region which are affected should have access, and that's where greater amount of funding. It might appear wishful, but then it is necessity. It's no longer a luxury that we invest in research and development. To conclude, Bundibugyo virus disease is a severe illness, but it's not a global threat in the way airborne viruses are spread. And transmission requires direct contact with body fluids, and therefore it can be contained in the local affected regions. This epidemic teaches us one important lesson. Our defenses are only as strong as their weakest link. Patient systems, kind of diagnostics, lack of financing, not being able to expand our testing for other viruses. These are very unglamorous things. These are the weakest links which have exposed our vulnerability. We need to invest in these missing links to be removed, strengthen the surveillance system. And by investing in surveillance and supporting frontline health workers and engaging communities and respecting human-animal environment interface, we can ensure that when the next virus surfaces, our tests will be looking in the right direction. And our response will start from day 0 instead of day 20. So let's learn this lesson now for the health systems before another test comes back negative for the wrong virus. Thank you. And leave your comments and tell me how I can improve communicating. The goal of me resorting to YouTube videos is to offer valid information, but how I can strengthen this is something that you can please suggest, and share this video if you think this is useful for you. And Until the next time, thank you for watching.